Okay, so this is June 4th. We are going to be doing a review of skeletal and soft tissue conditions and lower extremity conditions. This video is going to be focused on complex regional pain syndrome. See, I'm going to be using the pathology book, Implications for the Physical Therapist. And this is the out of the therapy ed book, Complex Regional Pain Syndrome, CRPS, formerly referred to as Reflex Sympathetic Dystrophy, RSD. The etiology is largely unknown but thought to be related to trauma or precipitating event, which can be multifactorial. Can affect upper and lower extremities, trunk, head, and neck. Results in dysfunction of sympathetic nervous system to include pain, circulation, and vasomotor disturbances. Physical therapy goals, outcomes, and interventions. Patient-client education for injury prevention and reduction. Desensitization activities to focus on return to work, school, home activities. Implementation of flexibility exercises to maintain and improve normal joint motion and length of muscles. Electrical stimulation TENS for pain relief. Two types of CRPS. CRPS1, frequently triggered by tissue injury. Term describes all patients with the above symptoms, but with no underlying nerve injury. Patients with CRPS2 experience the same symptoms, but their cases are clearly associated with a nerve injury. Medical intervention may include sympathetic nerve block, surgical sympathectomy, spinal cord stimulation, intrathecal drug pumps. Medications can include multiple forms, including topical analgesic drugs that act locally on painful nerves, skin, and muscles, anti-seizure drugs, antidepressants, corticosteroids, and opioids. Long-term changes include muscle wasting, trophic skin changes, decreased bone density, decreased proprioception, loss of muscle strength from disuse and joint contractures. Diagnostic tests utilized? None. Clinical examination will assist in confirming diagnosis. Looks like I'm out of drink. Okay, so this is from the pathology book. Paraneoplastic syndromes, rheumatologic associations, and clinical features. Excuse me. Rheumatologic associations, complex regional pain syndrome. Let's see. Table 3912, complex regional pain syndrome, progressive clinical stages. Stage 1, acute inflammation, denervation, and sympathetic hypoactivity. Begins up to 10 days following injury and can last 3 to 6 months. The classic signs and symptoms are pain, more severe than expected, burning or aching character, increased by dependent position, physical contact, or emotional disturbances. Hyperalgesia, lower pain threshold, increased sensitivity. Allodynia, all stimuli are perceived as pain. And hyperpathia, threshold to pain is increased. Once exceeded, sensation intensity increase more rapidly and greater than expected. Edema, soft and localized. Vasomotor thermal changes, affected limb is warmer. Skin hyperthermia and dry. Increased hair and nail growth. Stage 2, dystrophic paradoxic sympathetic hyperactivity. Occurs 3 to 6 months after onset of pain, lasts about 6 months. The pain worsens, it's constant burning and aching. You have allodynia, hyperalgesia, and hyperpathia, almost always present. Edema becomes thicker and more fibrotic, causing joint stiffness. Vasomotor thermal changes, either warm nor cold, neither warm nor cold. Skin, thin, glossy, cool, vasoconstriction, and sweaty. Thin, rigid nails. X-rays reveal disuse, osteoporosis, cystic, and subchondral bone erosion. Stage 3, atrophic. So you go from dystrophic to atrophic. Begins about 6 to 12 months after onset. May last for years or may resolve and reoccur. The pain spreads proximally. Occasionally the entire skin surface or plateaus. Joint stiffness progresses. Edema continues to harden. Vasomotor thermal changes. Sympathetic nervous system regulation is decreased on affected extremity. Affected limb is cooler. Skin is thin, shiny, cyanotic, and dry, blue and dry. Fingertips and toes are on involved extremity are atrophic. Fascia is thickened. Contractures may occur. X-ray demonstrates bony demineralization and ankylosis. Okay. So now we'll go to the reading on this particular pathology.
Complex regional pain syndrome, reflex sympathetic dystrophy, causalgia, abnormal response in peripheral nerves. Complex regional pain syndrome, reflex sympathetic dystrophy, causalgia. Complex regional pain syndrome, CRPS, first described in 1864, is characterized by sensory, autonomic, motor, and dystrophic signs and symptoms. CRPS includes disorders of the sympathetic nervous system with or without known trauma. New insights into nervous system function and pain mechanisms have led to reclassification of the syndrome. CRPSI, formerly reflex sympathetic dystrophy, is the label used to describe the syndrome when there is an absence of known traumatic nerve injury. However, there is usually an initiating noxious event. CRPS2, formerly causalgia, refers to a similar condition associated with known traumatic nerve injury. A third type, CRPS-NOS, not otherwise specified, only partially meets CRPS criteria and cannot be explained by any other condition. Incidence CRPSI may occur after 5% of all injuries, with a reported number of new cases each year of approximately 50,000 in the United States. Because the diagnosis is often missed or delayed, estimates on incidence may be underreported. Some very mild cases may resolve and others may progress to become a chronic, debilitating disorder. Although the average age of an individual with CRPS is in the mid-30s, it has been reported in all age groups, including children as young as 3 years. Women are 3 times more likely to develop CRPS than men. 42 etiology. CRPS has its origin in a variety of conditions. It can follow medical procedures, including surgery, such as arthroscopy. It can occur after an lesion arising from traumatic brain injury, cerebrovascular accidents, often in the presence of flaccidity, or destructive lesions of the CNS, or it can occur after LMN disorders from peripheral nerve injuries, neuropathies, and entrapments. CRPS has been reported following motor vehicle accidents, fractures, bites, human, animal, falls, assault, after a shoulder subluxation or dislocation, and even what seem like minor strains or sprains. Any event that causes traction of the brachial plexus and nerve roots resulting in constant nerve irritation may result in CRPS. Pathogenesis. CRPS is now regarded as a systemic condition that involves both central and peripheral components of the neuraxis and interactions between the immune and nervous systems. No one knows for sure what causes the cascade of neurogenic responses that leads to CRPS. Laboratory studies of blood and tissue samples appear normal, although there is some evidence of elevated systemic levels of inflammatory markers and catecholamines, mediators in sympathetic hyperactivity. Point 41 There is no apparent inflammation of the affected soft tissues, for example, skin, muscles. There is some evidence that the cellular changes are occurring within the nerve fibers to the affected tissues. An injury at one somatic level initiates sympathetic efferent activity that affects many segmental levels. CRPS is thought to represent a reflex neurogenic inflammation, facilitation of the sympathetic nervous system, SNS, and its neurotransmitters and catecholamines activates primary efferent nociceptors to create the sensation of pain. Deterioration of the SNS function is common. Excess release of substance P from terminal sensory nerves is part of the overreaction of the neurogenic inflammatory process. Migraine headaches appear to overlap with CRPS. The signaling neuropeptide CGRP, quercetin gene-related peptide, appears to be linked to the hyperresponsiveness in both migraine headaches and CRPS. Loss of inhibition in the complex cascade of nerve-related inflammatory chemicals that can occur after major or minor trauma suggests it's not the trauma itself that exaggerates the process, but rather the nervous system's response to injury. 18 It has been suggested that people with CRPS who lose their automatic nervous system reflex responses might have a faulty nervous system to begin with, which could explain why they develop CRPS when others with similar injuries recover normally. 206 Thermal dysfunctions are related to either the inhibition of SNS vasoconstriction or facilitation of the SNS causing excessive vasoconstriction. Figure 3919. Clinical studies have shown abnormal SNS reflexes that indicate CNS dysfunction exists as well. 213 Clinical manifestations. The natural history of CRPS is one of change over time. CRPS has overlapping but identifiable clinical stages. Table 3912. The primary clinical features of CRPS fall into four distinct subgroups. 1. Abnormalities in pain processing. 2. Skin color and temperature changes. 3. Edema, vasomotor, and sudomotor abnormalities. And 4. Motor dysfunction and trophic changes. Intense, burning pain in a specific area, most often an extremity, is the most commonly reported symptom. Other clinical manifestations vary widely and can include headache, difficulty sleeping, fatigue, difficulty concentrating, memory loss, edema, inability to initiate movement, weakness, tremor, muscle spasms, dystrophy, and atrophy. The cascade of neurogenic responses that leads to CRPS. Laboratory studies of blood and tissue samples appear normal, although there is some evidence of elevated systemic levels of inflammatory markers and catecholamines, mediators in sympathetic hyperactivity. Point 41 There is no apparent inflammation of the affected soft tissues, for example, skin, muscles. There is some evidence that the cellular changes are occurring within the nerve fibers to the affected tissues. An injury at one somatic level initiates sympathetic efferent activity that affects many segmental levels. CRPS is thought to represent a reflex neurogenic inflammation, facilitation of the sympathetic nervous system, SNS, and its neurotransmitters and catecholamines activates primary efferent nociceptors to create the sensation of pain. Deterioration of the SNS function is common. Excess release of substance P from terminal sensory nerves is part of the overreaction of the neurogenic inflammatory process. Migraine headaches appear to overlap with CRPS. The signaling neuropeptide CGRP, quercetin gene-related peptide, appears to be linked to the hyperresponsiveness in both migraine headaches and CRPS. Loss of inhibition in the complex cascade of nerve-related inflammatory chemicals that can occur after major or minor trauma suggests it's not the trauma itself that exaggerates the process, but rather the nervous system's response to injury. 18 It has been suggested that people with CRPS who lose their automatic nervous system reflex responses might have a faulty nervous system to begin with, which could explain why they develop CRPS when others with similar injuries recover normally. 206 Thermal dysfunctions are related to either the inhibition of SNS vasoconstriction or facilitation of the SNS causing excessive vasoconstriction. Figure 3919. Clinical studies have shown abnormal SNS reflexes that indicate CNS dysfunction exists as well. 213 clinical manifestations. The natural history of CRPS is one of change over time. CRPS has overlapping but identifiable clinical stages. Table 3912. The primary clinical features of CRPS fall into four distinct subgroups. 1. Abnormalities in pain processing. 2. Skin color and temperature changes. 3. Edema, vasomotor, and sudomotor abnormalities. And 4. Motor dysfunction and trophic changes. Intense, burning pain in a specific area, most often an extremity, is the most commonly reported symptom. Other clinical manifestations vary widely and can include headache, difficulty sleeping, fatigue, difficulty concentrating, memory loss, edema, inability to initiate movement, weakness, tremor, muscle spasms, dystrophy, and atrophy. The pain that occurs is disproportionate to what would be expected. The overall pain intensity increases with disease duration. Even tactile stimulation may be perceived as pain. Allodynia .70. The pain spreads from localized to a regional distribution, including to the same extremity on the contralateral side of the body in a mirror pattern. For example, right arm to left arm, comma to the other extremity on the ipsilateral side. For example, right arm to right leg, and to the other extremity on the opposite side. For example, right arm to left leg. Although sensory impairments are most often the hallmark of CRPS, movement disorders also occur. Motor symptoms may precede the appearance of other impairments by weeks or months, or may appear on the contralateral extremity in a mirror fashion, but most often they occur concomitantly with autonomic changes and pain. All manifestations contribute to impairments of function and alter quality of life. Despite the fact that 3 stages of CRPS were originally identified and are still referred to, the course of this disorder is more unpredictable than the stages imply. 103 individuals typically remain in a specific stage for 6 to 8 months. However, some may progress rapidly to and through the next stage. As the condition progresses, symptoms may spread proximally and even spread to affect other extremities. In a few cases, the entire body may become involved. 123 3 abnormal vasomotor patterns have been identified. These relate to the temperature and color, warmth or heat with redness, cool with bluish tint, of the extremity and the acuity of CRPS. Hypersensitivity and abnormal sweating may be followed by dry skin. Other vasomotor changes included changes in the nails in which they become thick, brittle, and rigid. Medical management diagnosis. In the absence of a specific biomarker, the diagnosis of CRPS is based primarily on the clinical examination and history. Proposed diagnostic criteria for CRPS requires at least one symptom in each of the 4 subgroups, and one sign in at least 2 of the 4 subgroups. A combination of diagnostic tests aimed at assessing secondary changes, radiographic examinations, thermographic studies, sudometer function tests, NCV or somatosensory evoked potentials, and laser Doppler flowmetry, may aid in establishing a diagnosis. Because of the evolutionary nature of CRPS, a correct diagnosis may be delayed, especially in children. 4984 Treatment. Treatment for CRPS tends to be multifactorial and prolonged. Successful treatment depends on early diagnosis, treatment of the underlying cause, and aggressive and sustained physical therapy. 88 Although stellate ganglion blocks or sympathectomy are used to alleviate pain and early symptoms, this approach is based on weak evidence. 120 To all of the following treatments have limited evidence for their effectiveness. 68 Medications such as corticosteroids, non-steroidal anti-inflammatory drugs, antidepressants, anti-anxiety agents, and anticonvulsants may offer pain relief by normalizing overactive pain pathways but do not vary the duration of the disease. Amitriptyline has been used to facilitate sleep and relieve depression. Calcium channel blockers help to improve peripheral circulation through their effect on the SNS. Newer, more selective drugs, for example, immunomodulators, are showing promising results. 173 IV ketamine infusion has been used in severe cases unresponsive to other therapies. This drug works by shutting off the N-methyldeaspartate receptors in the brain but must be supported by a wide range of other management tools. For example, good nutrition, physical and occupational therapy, exercise, cognitive behavioral counseling. .70 Sympathetic. somatic, and trigger point blocks, spinal cord stimulators, and intrathecal pumps for the delivery of beclofenomorphine decrease pain intensity and perception of pain, but do not alter the disease progression. A less expensive alternative may be the use of hyperbaric oxygenation therapy used to restore circulation, reduce inflammation, and eliminate swelling in affected limbs while also changing pain processing in the brain. This is not yet approved by the FDA and results reported so far are based on case studies. 127 Integrative medicine has a role in the treatment of chronic conditions like CRPS. Some people find relief from their symptoms, or at least an ability to cope better and improve function, when traditional allopathic medicine is augmented by acupuncture, craniosacral therapy, body talk, Reiki, Tai Chi, yoga, or other forms of complementary care. Cognitive behavioral therapy, although not a cure for CRPS, can help improve pain, mood, and function. 85 Prognosis. CRPS is a complex syndrome with varying severity and disability. In many cases, the pain continues for years or, less frequently, it may remit, then recur after another injury. Spontaneous remission is unusual. Only modest improvement have been reported with most current therapies, 173 in some cases. Malingering for secondary gain has been documented. 218 outcome measures for CRPSI typically concentrate on impairments, leaving measurement of disability, which is the most relevant to function. With few assessments, 168 physical therapy is indicated, particularly as part of a program of pain control, although the goal is to maintain function so that the individual can perform normal activities, a vigorous approach is not indicated. Current research is aimed at understanding physiologic processes and finding the most effective interventions. Special implications for the therapy's 3911 complex regional pain syndrome goals for physical therapy include educating the client and encouraging normal positioning and use of the involved extremity while minimizing pain and normalizing sensation. Stress loading and scrubbing, is a key part of the rehabilitation program. Weight bearing and compression through the affected extremity is followed by a distraction force, for example, carrying weights or a bucket with weights inside. Scrubbing is performed on hands and knees or for just lower extremity involvement in the standing position. A scrub brush held in the hand or attached to the foot is held with constant pressure against the contact surface and a scrubbing motion applied in various directions. All scrubbing and loading activities are done daily with gradual progression to tolerance. At first, there is often an increase in pain and swelling with this type of program, but these symptoms decrease after a few days. Desensitization techniques may also assist in normalizing sensation to the affected area. This consists of progressive stimulation with very soft material to more texture fabrics or materials. Sensory input is graded from light touch to deep pressure and from consistent to intermittent duration with each material. There is evidence that graded motor imagery reduces pain and swelling in some people with CRPS. This approach involves recognizing pictured hands, or whatever body part is affected, as being right or left, imagining movements, and mirroring movements. The affected individual must practice hourly for several weeks to have an effect. 136-138 Although modalities are used to provide pain relief, the greatest success occurs when they are administered during earlier stages of CRPS. External transcutaneous electrical nerve stimulator units are reported to be minimally effective. 31 When the lower extremity is involved, aquatic therapy is helpful for improving mobility when weight bearing on land is problematic. The therapist should be aware of the potential for significant psychologic, emotional, social, and spiritual issues associated with any chronic condition, but especially one as painful and debilitating as CRPS can become. Furthermore, because the pain is often disproportionate to the incident, people with CRPS may be misunderstood by their loved ones and by clinicians. Attentive listening, acknowledging and validating feelings of anger, worthlessness, anxiety, depression, and hopelessness, referral to support groups, and communication with the physician about the individual's needs are essential during the long process of recovery. A report of increased spontaneous falls throughout the course of the illness has been documented for more than a quarter of individuals with CRPS. It would be advisable to conduct a falls assessment and institute client safety education and falls prevention. 173.
Okay, so that is the reading from the pathology book. right here. And we already looked at that. Okay, so let me go ahead and pause this. Okay, so I haven't checked it out yet, so I don't know if this YouTube video is going to play. So we'll end the video after this so I can see if it's going to work or not.
Complex regional pain syndrome, or CRPS, formerly known as reflex sympathetic dystrophy, or RSD, is a chronic condition that causes persistent burning pain and swelling in your arms, hands, legs, or feet. Your body's normal response to an injury begins when pain receptors deliver pain messages in the form of nerve impulses to your brain. Once these impulses reach the pain centers in your brain, the pain centers generate new impulses and send them through your sympathetic nervous system to the area of injury. The sympathetic impulses trigger an inflammatory response, causing blood vessels to expand. The inflammatory response also leads to swelling and redness in the damaged tissue. As your wound heals, the swelling and redness subside and the pain goes away. However, if you have complex regional pain syndrome, the pain and swelling do not go away after your wound heals and may worsen over time. Although the exact cause is unknown, one theory suggests that after your injury has healed, abnormal impulses continue to travel along nerves to your skin and blood vessels, stimulating the inflammatory response. There are two types of complex regional pain syndrome, though the symptoms are the same for both. If you have CRPS1, your condition may have been triggered by an illness or injury, but you do not have a nerve injury in the affected area. If you have CRPS2, your condition is clearly linked to a nerve injury in the affected area. Treatment of complex regional pain syndrome is focused on pain management, as there is no cure for this condition. Your treatment options may include pain medication, physical therapy, a nerve block, implantation of a pain-controlling device, surgery, and psychosocial support.
Okay, so I don't know if I think it's going to play though. Ooh. Mm-mm. I think it played the wrong one. Okay, we're going to
Okay, I cannot wait to see what these look like.
stop this here.
This was the sweetest surprise.
This is the one that I wanted here.
Laxity, or sagging, is the #1 skincare concern among women over 40. So it's easy to see why collagen creams have become increasingly popular in recent years.
We don't want to do the ads, do we? No.
Complex regional pain syndrome, or CRPS, is the topic. CRPS is basically a neuropathic pain that can happen in a chronic state. CRPS1 involves pain that occurs after bone injury, and then CRPS2 happens after there's some sort of nerve injury. Let's talk a little bit about CRPS type 1. Typical scenario is that a woman, because it's 2 to 3 times more common in the females, has some sort of injury. Most commonly in clinical vignettes they talk about a crush injury, usually the lower extremity, the lower limb. And then some months later she presents with the signs and symptoms of CRPS1, which is this chronic pain that doesn't seem to go away. And I'll go into the signs and symptoms a little bit later. But that's the typical scenario. Now, before I talk about the symptoms, I want to talk a little bit about the pathophysiology of why this happens. What exactly is going on here? Why does somebody continuously have pain months after the injury occurred? Well, there's sort of this positive feedback cascade or loop that tends to occur. First you have the injury, which is the initial event. And then what happens is the brain In particular, the sympathetic nervous system responds, and it responds by releasing a neurotransmitter. And the neurotransmitter that we're referring to is norepinephrine. And norepinephrine, what happens is, as many of you know, it causes some effects on the body, and one of those effects is vasoconstriction of the vessels. And that vasoconstriction actually leads to vessel spasm. The vessels start to spasm, and that leads to pain. And it can also, in addition to leading to pain, it can also lead to inflammation. And then once you have pain, it's kind of like it goes back into the same cycle where the brain senses it again and again releases norepinephrine. So this just keeps going round and round, and it's a pretty tragic occurrence if it does happen to someone. So let's talk a little bit about the symptoms. Fortunately, the symptoms are pretty distinct, especially if they're put all together. Pain, but in particular, you have this burning pain, and that's commonly talked about on clinical vignettes. Then you have these cutaneous changes, the cutaneous referring to the skin. The skin can be red, the skin can have an increased temperature, the skin can be hyperhidrotic, meaning there's sweat, and then they can also be edema. So I encourage you to look up a picture of CRPS 1 online, and you'll see what this looks like. And then also the range of motion can be decreased. And then another thing that happens in CRPS is that you have the psychological presentation, psychological distress, because it's such a unbelievably tragic and debilitating condition. The person can develop depression and can also feel angry, because oftentimes it's a very difficult diagnosis. So how do you diagnose it? Well, other than the clinical criteria, which is the way the patient presents with their history and their symptoms, there is some very key things that you need to look for. And those two things that you need to look for are allodynia and hyperalgesia. And I'll explain what each of these are. And to be honest, this is probably going to be, by most standards, done by a pain specialist. It's probably something that a patient has gone to their regular doctor and then has been referred. So allodynia basically means that the patient has pain from stimuli that normally don't cause pain. So I'll give you an example, which are not normally painful. So for example, an example of allodynia is you take a Q-tip and you just brush the Q-tip along the patient's skin. And normally that's not going to cause any pain to anybody, but with a person with CRPS, it will. So that's an example of allodynia, pain from stimuli which are not normally painful. Now we get to hyperalgesia. What's that? Well, this is basically a condition where the patient has increased pain to a painful stimuli. And I'll explain what that means. So for example, let's say a normal person, you prick their skin with a pin. And you say, well, how much pain did that cause you? And they say, well, on a scale from 1 to 10, it was about 3 out of 10. Then you take a patient with a CRPS and you do the same pin prick, and then you say, well, how much did it hurt you on a scale from 1 to 10? And they'll say, whoa, that was really painful. So that's what's happening here. Increased pain due to a painful stimuli. That's another characteristic of CRPS. And then one final thing about diagnosis is that, interestingly, there is a procedure that a pain doctor can do called a sympathetic nerve block. And this is definitely a very specialized procedure. This is actually used as a diagnostic tool. And the reason is because if you do this for the patient and the symptoms of the pain are relieved, then that actually is diagnostic of CRPS. So it's one of those things that's used for diagnosis and used for treatment also. So if a pain specialist has a suspicion of CRPS, this can be used as diagnosis and treatment as well. So that brings me to the treatment, the sympathetic nerve block. And then the next one are the pain medicines, in particular the opioid analgesics. And then the third and final is an absolute must, and that is physical therapy. So these are the three of the fundamental aspects of the treatment of CRPS. So let's take a look at some vignettes. A 45-year-old woman experiences a crush injury of her right lower extremity. Some months later, she presents to a pain specialist complaining of burning pain in her affected extremity. She states that when she feels stressed, the pain gets worse. She also states that all this has made her depressed and frustrated. On physical exam, the specialist notices that she has hyperhidrotic skin, which is visibly red, edematous, and warm to touch. Her range of motion is also limited. The specialist decides to try a sympathetic nerve block, as this can be used for diagnosis and treatment of the suspected condition the patient has developed. After administering the regional sympathetic blockade, her pain is relieved. Which of the following conditions does she most likely have? Well, this is a classic clinical vignette that encompasses all aspects of CRPS. So it's very nice, and E would be the right answer, of course. And then finally, several months after sustaining a crushing injury to his arm, a patient complains bitterly about constant burning, agonizing pain in that arm that does not respond to the usual analgesic medications. The pain in his arm is aggravated by the slightest stimulation of the area, such as rubbing from the shirt sleeves. The arm is cold, cyanotic, and moist, but is not swollen. Pulses at the wrist are normal. A neurologic function of the three major nerves is intact. Which of the following is most appropriate to provide diagnostic confirmation of the nature of the problem and eventual therapy? Well, it's a very good question. I like this part here. Slightest stimulation of the area, such as rubbing from shirt sleeves. Now that is an example of which one? Allodynia. Because remember, allodynia is pain from stimuli which are not normally painful. So normally if you have rubbing from your shirt sleeve, it's not going to cause you any pain. But in a person with CRPS, something like that will. So that's a perfect example of allodynia. So this patient has all the features of CRPS, and you want to do something that will diagnose it. And remember, a sympathetic nerve block will do that. It will help you diagnose it, because if the patient's pain is relieved, then that clinches the diagnosis, and interestingly, it also treats the CRPS. Provide the diagnostic confirmation is basically what they're asking, and they're also even telling you that it will be an eventual therapy. And the answer to this question would be E, sympathetic nerve block.
Okay, well, I sure do hope that got in my video, so I'm going to stop the video here and take a look at it.